now we are recognizing that preverbal events, so younger than 3, as well as prenatal in utero events can result in trauma, as well as intergenerational trauma, so what's happened in previous generations. And there's some excellent research out now looking at epigenetics and how those kinds of events like the Holocaust or any kind of trauma, even something like sexual trauma, can change your epigenetics and then can be passed down into subsequent generations. So this is sort of an overview of the different sources of trauma, but that isn't the definition of trauma. We now think of the trauma as a subjective experience, as our response to an event or a series of events that overwhelms our capacity to cope. And this is a really important change in the definition because it takes the onus of the diagnosis of trauma away from the other person who sits there and says, oh yes, your event was sufficiently traumatic enough that this warrants a diagnosis of PTSD. It's really the response and our subjective experience of that. And this idea of overwhelming our capacity to cope, which is also subjective. One person's capacity to cope is going to be different than another person's capacity to cope. And there's evidence now that our attachment styles, how we were able to attach to our caregivers early on, really adjusts our capacity to cope with stressors or traumas in the future. And so that reduces our threshold for having a traumatic response to an event. So what we see is that trauma is sort of this event, or the physiological response to an event causes the dysregulation across the nervous system and its interfacing systems, so the digestive, the immune system, the inflammatory system. And when this happens, we see multiple symptoms arise across these body systems. And they can occur all at the same time. So I would see many children or adults with many symptoms. So they have sleep problems, they have digestive problems, they have anxiety and panic attacks, they have chronic headaches, and they have the hypertension. So you start to, the list of that review of systems that we do often as clinicians, the list of symptoms starts to add up because we're involving the whole nervous system, all the different subdivisions of it and its interfacing systems. And sometimes they can occur in tandem. So the migraine disappears, but now we're dealing with irritable bowel syndrome, and then irritable bowel syndrome gets better, and now we're dealing with vertigo. So either these things can happen in tandem. So invariably, these symptoms are triggered or exacerbated by stress. And we often think of stress as sort of psychological, the psychological stress, but stress can also be physical, right? We can overexert ourselves, and that can generate these symptoms. Or it could be something fun. I had one patient, every time he went to a birthday party, he threw up. So
of joy.
And he would throw up. And this is sort of, there's a stressor, there's that increased, that excitement, his whole nervous system gets activated, and then his vagus nerve comes on, and then boom, he throws up. So, it's not always a bad threat. And then often there's reduced resilience. So if they overexert themselves, the symptoms come on, and it takes longer to bounce back from the stressor. And as clinicians, we don't test the function of these subcortical and autonomic systems other than doing HRV, which we'll talk about. So these medical symptoms will go unexplained and untreated by healthcare providers. And that was my experience over and over again when I worked in the medical system. And if it's kind of like treating these symptoms with, just to try to help the symptom and not addressing the underlying problem is like treating pneumonia with Tylenol, right? You have the symptom of a fever, but what's actually happening in the body is a pneumonia. And you can't treat that with Tylenol. You have to treat the underlying pneumonia. So all of these medical symptoms are being treated symptomatically, but what's actually happening under the hood